Very much, Rose, for your kind introduction and sharing this session. So these are my conflicts of interest. So when we talk about selecting patients for endoluminal therapy, we have to think about all the possible options we have, going from surgery to primary ablation or endoscopic resection. And whenever we make that decision, we need to keep the balance between oncological safety, that comes first. So when surgery is necessary, we need to do that. But we need to also consider procedural safety and technical feasibility. So obviously for surgery, this is a larger burden on the patient. So whenever we can be conservative and provide an endoscopic ablation technique with resections and potential subsequent ablation, I think it's preferable for those patients. However, we also need to be careful about not over-treating patients. And the very first step in case of finding dysplasia and Barrett is to have it confirmed by a very experienced GI pathologist. This is actually something that determines the entire treatment path. And with regard to that, the presence of inflammations is something that needs to be taken into consideration when you have a diagnosis of high-grade dysplasia in a pathology report. Because if this is the case and you have an esophagus like this, these reactive changes are probably more inflammatory, and you need to repeat the endoscopy after 8 weeks of high-dose PPI. So you need to take a step back and not rush into treatment with ablation here. On the other hand, if you see something like this, where there's clearly a visible lesion, you should not underdiagnose this as potential only high-grade dysplasia because it's cancer until proven otherwise. I think this is the key of selecting patients for the correct treatment in case of dysplasia and Barrett's esophagus. Because the very first thing to do is, if you find a visible lesion like this, as mentioned in every Barrett's guideline, is that it should be removed by an endoscopic resection technique. If we look at this, at the success of the EURO2 trial, for instance, and other RFA trials, one of the key factors is the removal of all these lesions. So the high success rate depends on this. If you look, for instance, at the EURO2 trial here, you can see that the majority of the patients, in fact, did undergo an endoscopic resection of visible lesions. And prior to RFA, the majority of the patients actually had no residual dysplasia or maximal low-grade dysplasia. Note that only 36 had residual high-grade dysplasia on 2 Seattle protocols prior to ablation. And if one of those 2 Seattle protocols showed cancer, the patient was out of the study. So we need to take these stringent selection criteria into consideration to obtain the same clinical results outside of the study protocols. And this is nicely shown by Rayan's study, showing a significant improvement by the augmentation of the higher adaptation of endoscopic resection prior to RFA in the 2 different periods in this study. So if you compare what happens here between 2011 and 2013 and 2008 and 2010, you can see that the outcome for complete remission of dysplasia significantly improved after endoscopic resection was applied more prior to RFA to remove all visible lesions. So this is really key, because endoscopic resection provides us with histology to determine the correct treatment for patients. If we have deep submucosal invasion, lymphovascular infiltration, or poorly differentiation grade, we know we need to consider to send the patient to surgery, because then the risk of finding lymph node metastases will increase significantly. So this is associated especially with deeper submucosal invasion or any of these factors. And we cannot depend on an endoscopic biopsy alone, because we know that the accuracy of this pre-endoscopic resection biopsy, if we compare this to the final EMR result, that this is only 61%. And even for low-grade dysplasia, this is true. For instance, this small lesion showed low-grade dysplasia on the biopsy, but turned out to be a mucosal cancer after endoscopic resection. So any dysplasia should be resected for accurate histology. So this is the first standard of good practice, that all these visible lesions, regardless of the degree of dysplasia, should be removed. However, as Rayan pointed out, it's very disappointing to see that finding these lesions is still quite difficult. So a major problem remains. In this nice study from Jack Berkman, 40% of patients with known dysplasia were referred without a significant lesion, but in 3 out of 4, an experienced endoscopist was able to find a lesion. And know that 4 of these patients were sent straight to surgery without even considering endoscopic therapy. So the importance of thorough inspection cannot be emphasized enough. So if you find a small nodule here, which is situated at 6 o'clock position in this patient, you take a biopsy and it showed only high-grade dysplasia. So we scheduled the patient for EMR a couple of weeks later, and then to our surprise, the final EMR showed a deep submucosally invading tumor, which was poorly differentiated. So obviously here the patient needed surgery, and if we would have ablated the patient on the assumption that he only had high-grade dysplasia, he might have missed his window of opportunity for curative resection. And imaging here really works. This is a patient referred with an inconvenient situation, a C3M4 without visible abnormalities, and they took 2 biopsy containers, and one of them showed invasive adenocarcinoma, but the referring physician was not able to relocate the lesion. And then if you use everything in your toolbox, you can find these lesions. First of all, you can see slight friability here after first passage. You see this dark halo of altered vascular pattern around this mucosal island, a squamous mucosis island. And then you can see also a red halo of early loss of acetowidening after acetowidening. And then we hit the bullseye by resecting this lesion and showing a small adenocarcinoma that was completely resected. So these techniques work, and we should use them in daily practice to augment our detection skills and possibilities. Another question for selecting patients is whether we need to have endosonography, and we tend not to do this for small lesions like you see in the first 2 examples. But when lesions get more bulky and the risk of submucosal invasion is estimated to be higher, obviously then we do a full staging to avoid perform an endoscopic resection in a patient with metastatic disease. What about ESD? We know that EMR works very well. We know this large series from Germany with 1,000 patients with intermucosal adenocarcinoma showing long-term results of long complete remission in 94%. ESD is another solution, but this randomized trial from Düsseldorf actually showed indeed a higher R0 resection, but this does not translate in a better complete remission and comes to the expense of more severe adverse events. So how do we fit this? What should we do? Because both of them allow deep staging. Well, things to consider is to wonder whether you can go deep enough to get an adequate deep resection. And this could be more important if you think about a potential curative treatment in an operable patient. So for instance, if you accept an SM2 lesion to be curative, you still have a 20%, 80% chance of curing the patient if he's inoperable. Also, in case you think that the lesion cannot be treated with EMR, ESD can be an option. But we always have to consider cost effectiveness because we know it's more time consuming and more expensive to do ESD. But probably there's a place for more advanced lesions with higher chance of deeper submucosal invasion to obtain complete resection and staging, or for recurrences with fibrosis. We tend in our practice to remove most of the lesions with EMR. So most of them are flat and 20 to 30 millimeters, but when they get bigger and become more bulky, then we consider to perform an ESD nowadays. So EMR is the preferred resection technique, but ESD is gaining interest, and we can resect lesions up to superficial submucosal invasion, provided they have no lymphovascular infiltration and are not poorly differentiated. Extended criteria should be regarded as experimental and entered in follow-up protocols. So this covered the resection technique and selection of patients. So where does RFA or ablation techniques come into play? Well, the concept of the 2-step concept for Barrett's dysplasia comes actually from an APC trial, where randomization showed that in the long term, metachronic neoplasia was significantly reduced by additional ablation. And this has now been reiterated in several trials, the EURA2 trial, and also outside of trials, to show really excellent outcomes in terms of complete remission of dysplasia and complete remission of intestinal metaplasia, respectively being more than 90% and around more than 80%. But also for low-grade dysplasia, this works. The SURF trial randomized patients being follow-up, showing that ablation of low-grade dysplasia significantly reduced the risk for progression of high-grade and early adenocarcinoma. However, here also comorbidity needs to be taken into consideration because there's still a chance to pick up the patient in a later stage and treat them curatively. Even if you have low-grade dysplasia, this may be an indication of more prevalent disease. Like in this case, a patient that was selected for that SURF trial and was recalled. And we actually found 2 lesions showing intermucosal cancer in a patient only having low-grade dysplasia. He was subsequently treated with circumferential ablation and then also with additional Halo 90 focal ablation, and we managed to get complete remission after a couple of months. So these techniques really work very elegantly, I think, but we need to keep this paradigm into our minds, so we need to get it confirmed. And only when we're absolutely sure there's no dysplasia with visible lesions or cancer in the biopsies, then we can go for primary RFA. But remember, in all the other ones, we need to have a resection to get accurate staging and further treatment. So endoscopic treatment is a two-step procedure. We remove the lesions and then do an ablation, and RFA is the preferred technique and best studied technique for removal of the cancer and visible lesions of residual low-grade dysplasia and high-grade dysplasia, or to consider it as a primary ablation for high-grade or low-grade. Finally, what about non-dysplastic? I think this is a no-go zone. It's the final thing. First of all, the risk for progression is pretty low. It's a maximum 0.5% per year. We need to consider the complication rate. Severe complication rate is low, but bleedings have been reported and can be severe after RFA. So we need to balance this against the non-malignant character of the disease. And we need to also take into consideration that post-procedural patients do have symptoms, and they didn't have symptoms before. And this is very often a reason to drop out. And the most important part is probably that we're not really sure what we're doing in the long run. At least if we look at this APC study from Brussels, you can see that there's still a risk of more than around 1% to progress to cancer in this small study with 31 patients treated with APC. And finally, the cost-effectiveness study showed that surveillance and surgery at detection, or surveillance and RFA at detection, and initial RFA and surveillance were compared here. The first one was never effective, and the second one was the most effective. And initial RFA and surveillance was not cost-effective for several progression rates, not reaching the cutoff of $100,000 per gained QALY. So this is the final standard of good practice and principle. We do not ablate non-dysplastic Barrett's. And I would like to conclude here, Rose, and give the word back to you.